Thermal burns are, well, they're a really serious health issue. And when you start looking into resources like the textbook Hyperbaric Medicine Practice, you really begin to see just how complex treating them can be. So today we're doing a deep dive into Chapter 31. It focuses on something called Adjunctive Hyperbaric Oxygen Therapy, HBO2 for short.
Right, HBO2, and how it might help treat these burn injuries.
Exactly.
And we're drawing on some, really solid information here. It's straight from the experts in hyperbaric medicine.
Good.
Our goal today really is to explore the evidence behind using HBO2 as like a supplementary treatment for burn injuries. We want to give you a clear picture of what the science and also the real-world clinical experiences are actually showing us.
Okay, let's unpack this then. So when we talk about using HBO2 for burns, what's the basic idea? Like, why even consider it in the first place?
Well, the core argument, as the chapter's abstract lays it out, it's pretty compelling. The idea is that HBO2 can help stop the skin around the burn from losing its blood supply. That's dermal ischemia.
Okay, ischemia, lack of blood flow.
Precisely. And it can also really cut down on the swelling, the edema, which is, such a big problem with burns. Plus, HBO2 seems to positively affect that area called the zone of stasis.
The zone of stasis, right.
Yeah.
What's the significance of that particular zone?
Okay, so think of it like the area right around the worst part of the burn. It's not totally destroyed, but it's definitely in trouble.
Okay, vulnerable.
Exactly. HBO2 is thought to help stop this zone of stasis from getting worse, from becoming a deeper, full-thickness burn. It's also believed to help keep the cells in that fragile area producing energy, maintain their metabolism.
And that helps healing.
And ultimately helps speed up the whole healing process, yes. And the clinical reports mentioned in the chapter, they suggest some pretty significant real-world benefits, too.
What sort of benefits are we talking about here?
Things like lower mortality rates, patients spending less time in the hospital, needing fewer surgeries.
Fewer surgeries, that's big.
It is. And even lower overall cost of care. Plus, the chapter really stresses that HBO2 seems safe, when it's given by trained professionals who are monitoring the patient closely.
Okay.
But, and this is really key, it's not for everyone. You have to carefully select the patients who are most likely to actually benefit. That's essential.
That makes total sense. You wouldn't just throw any therapy at every patient. Now, to really get a handle on the scale of the burn problem, this chapter points to some pretty massive data, right, from the National Burn Repository.
Exactly right. They looked at a huge data set covering 2006 to 2015, over 205,000 records from almost 100 hospitals across, 36 states and D.C.?
Wow.
Yeah, it gives us a really broad view of burn injuries in the U.S.
And what did they find? What were some of the key takeaways from all that data?
Well, several things kind of jump out. First, burns tend to hit men more often than women.
Okay.
And there's an interesting age pattern, like a bimodal distribution. A big chunk happens in young kids, 1 to 15 years old, about 30%. Then another big group, over half, are adults between 20 and 59.
And older adults.
About 14% are 60 plus. Interestingly, though, the vast majority, over 75%, were relatively small burns, less than 10% of the total body surface area, or TBSA.
And thankfully, those smaller burns had a pretty low mortality rate. Right?
Yeah, 0.6%, very low.
But the overall risk of death from burns is still a major issue, isn't it?
Oh, absolutely. The overall mortality rate in that data set was 3.3%. But that figure jumps to 5.8% if you look just at injuries from fire and flames.
And where are these happening mostly?
Sadly, the data showed most of them. About 73% happened at home, and nearly 95% were classified as accident.
Accidents at home. That's sobering.
It is. Work-related burns were about 14%, and there were smaller percentages for suspected abuse, just over 2%, and self-inflicted, around 1%.
So those are tough numbers. Did the data show any positive shifts over that 10-year period?
Yes, actually, there were some encouraging signs. The average time patients spent in the hospital actually went down for both men and women.
Oh, good.
Yeah, females from 9.3 to 7.9 days, males 9.1 to 8.8, and we also saw mortality rates decline for both sexes, too.
That's progress.
It is. But the data also really reinforced some key risk factors: advancing age, the size of the burn, and crucially, whether the patient also had an inhalation injury, smoke inhalation.
Right.
Those things all significantly increase the risk of death. So a key point here is, yeah, smaller burns have lower mortality, but there are so many of them, and the cost adds up. Plus, when you add inhalation injury or older age, the mortality risk shoots way up.
Which highlights the need for therapies that can help across the board.
Exactly, which is where the potential for something like HBO2 comes into the picture.
What about other problems? complications.
Yeah.
What were the big health issues coming out of these burns?
Pneumonia was the big one. The most frequent complication reported, especially for fire or flame injuries.
Oh.
And it was even more common if patients needed a ventilator for 4 days or more.
Makes sense.
For survivors, their average hospital stay was roughly a day for every percent TBSA burned.
Wow, okay, so a 30% burn means about a month in the hospital.
Roughly, yeah. But for those who unfortunately didn't survive, their hospital stay was, on average, twice as long.
Twice as long?
Yeah. Although, interestingly, that flipped for smaller burns, less than 20% TBSA.
Okay, now this is where it gets really interesting. The money side. Treating severe burns must be incredibly expensive.
Oh, it's astronomical. Just to give you an idea, back in 2015, the average hospital charges, just the charges for someone with a 59% TBSA burn, were over $1 million.
$1 million.
And for 70% TBSA, burns even higher. The data also showed that the total charges for patients who died were generally 3 times greater than for survivors.
3 times?
Yeah. But even for those smaller burns, less than 10% TBSA, the cost for non-survivors was still significantly higher, about $340,000 versus $257,000 for survivors on average.
So the economic burden is just huge.
Massive, which really highlights the potential impact if HBO2 can cut complications and boost survival.
Wow. And who's footing these enormous bills? What do the data say about insurance?
Well, interestingly, workers' comp or auto insurance only covered about 10% of cases.
Only 10%?
Yeah, and a surprisingly big chunk, almost 29%, was listed as no info or self-insured.
So the patient or family likely carried a lot of that cost.
Very likely. The repository also pointed out the common complications that really drive up mortality risk, things like pneumonia, cellulitis, which is a skin infection, respiratory failure, UTIs, wound infections, and sepsis.
Sepsis, that systemic infection, always dangerous.
Always.
So with all these challenges, what are the main goals when treating burns? It's got to be more than just keeping the person alive, right?
Absolutely. Survival is priority number 1, obviously, but the goals go way beyond that. Rapid healing, minimizing scars, preventing long-term issues like chronic pain.
Chronic pain's a big one.
Huge. And importantly, being cost-effective, the ideal outcome is helping the patient get back to their pre-burn quality of life as much as humanly possible.
This chapter also mentions what experts see as the big research priorities in burn care, doesn't it? What are they trying to figure out next?
Exactly. A report by Wolf and colleagues flagged several key areas. One big focus is managing that intense inflammatory response the body has after a burn. Too much inflammation can actually slow down healing.
Okay.
Another priority is finding ways to just speed up healing time. And crucially, there's a huge need for better ways to tackle pain, both the immediate acute pain and that awful chronic pain many survivors deal with.
Especially neuropathic pain. Nerve pain.
Yes, that's particularly tough to treat. And they specifically mention HBO2's potential role in modulating that inflammation we talked about. Definitely an area of interest.
It really sounds like a major burn affects way more than just the skin.
It absolutely does. The chapter even calls a severe burn a universal trauma model.
Universal trauma model.
Yeah, emphasizing just how systemic the body's reaction is and how critical it is to control that hypermetabolic state and massive inflammation. And with early surgeries, seemingly hitting a bit of a plateau and speeding up healing for the worst burns.
Meaning we're not seeing huge improvements anymore just from cutting out the tissue early.
Right, for the really severe cases. So the author suggests maybe it's time to revisit other approaches, like HBO2.
Okay, so we get that severe burns are a huge health and economic challenge. Now, let's get into the why behind HBO2. What's actually happening physiologically after a major burn that makes HBO2 potentially useful?
Right. So immediately after a big burn, the body kicks off this whole complex cascade of responses. You get a quick drop in blood pressure, heart rate speeds up.
Tachycardia.
Yep. But the amount of blood the heart pumps out, both per beat and overall cardiac output, actually goes down. Metabolically, you see this shift towards acidosis, and the person might start hyperventilating, breathing really fast.
Okay.
And crucially, down at the cellular level, the cell's energy currency, ATP, starts to drop. This messes with the electrical potential across the cell membrane, and electrolytes, sodium, calcium, potassium, water start moving in and out of cells abnormally. It's like widespread internal chaos.
Sounds like the body's in a state of severe shock.
It's definitely a form of shock. And the immune system gets hit hard, too. Macrophage function changes, cellular immunity, humoral immunity, it's all disrupted.
Wow.
And then locally, at the burn wound itself, you have those zones we mentioned, coagulation, where tissue's dead, stasis, the critical at-risk zone, and erythema, the red zone around it.
And that zone of coagulation, the dead tissue, it can spread.
It absolutely can. It can get significantly bigger and deeper in the first 48 hours. A burn isn't static. The damage keeps progressing initially.
So it's a really dynamic, unstable situation in those first hours.
Totally. The microcirculation, those tiny blood vessels, are most compromised in the first 12 to 24 hours, but things can stay unstable for up to 72 hours.
And that leads to
Ischemic necrosis cells dying from lack of oxygen. You also get tiny clots forming, platelet microthrombi, and blood thickens up in the small veins, hemoconcentration, and then there's the edema, the swelling.
that massive swelling you often see.
Exactly. It happens fast in the burn tissue because the blood vessel walls get leaky, fluid holding pressure inside drops, pressure outside increases, pulling fluid out, the tissue's ability to expand changes, and even the lymphatic drainage system gets damaged. Wow. And what's really concerning is this edema isn't just local. It can pop up in distant, uninjured tissues too. Muscles, gut, even the lungs.
So swelling far away from the actual burn.
Yes. And even in those distant tissues, you see changes in the microvasculature.
What kind of changes happen there away from the direct injury?
Things like red blood cells clumping, white cells sticking to vessel walls, little platelet clots forming, and this is all fueled by inflammatory mediators.
Chemical signals released by the body.
Right. Released locally by activated platelets, macrophages, leukocytes, they contribute to that widespread leakiness in the microcirculation, basically punching more holes in the vessels, letting more fluid escape. The damage can really snowball in those first few days.
It really sounds like a vicious cycle, damage just spreading.
It is. The ongoing damage in that zone of stasis is mostly because cells there are starved for oxygen and nutrients due to the bad blood flow. Plus, the damaged skin barrier lets moisture escape, drying things out desiccation because fluid can't get to the surface.
And it's not just the heat causing the leaky vessels.
No, it's also inflammatory stuff, oxidants, prostaglandins, kinins, histamine, they all play a role. And neutrophils, a type of white blood cell, are a major source of those damaging oxidants, especially during ischemia perfusion.
Ischemia perfusion. Blood flow stops, then starts again, causing more damage.
Exactly. A similar process happens in burns.
So with all this cellular mayhem going on, what are the main treatment goals right at the start?
The big focus is trying to reduce that dermal ischemia, minimize the edema, and crucially, prevent infection. Cutting down the swelling early is really important, not just for stabilizing the patient, but also because it might stop a partial thickness burn from turning into a deeper, full thickness one later.
So addressing those core problems early limits the overall damage.
That's the goal, improve the chances of a better outcome.
Okay, let's pivot to that huge concern, infection. The chapter says it's still the leading cause of death overall for burn patients. Why are they so vulnerable?
Several big reasons. First, the obvious one, the skin barrier is gone. Skin's our first defense, and when it's breached, microbes can get in.
Right.
Second, the burn wound itself is like a perfect petri dish for bacteria, warm, moist, lots of nutrients.
Right.
And third, as we talked about, that damaged microvasculature makes it hard for immune cells and antibodies to actually reach the injured tissue where they're needed.
So the body's defenses are crippled right where the attack is happening.
Exactly. And it's even deeper than that. The burn itself messes with the whole immune system. You see lower levels of immunoglobulins, those infection-fighting proteins, and the function of specific white blood cells, the PMNs, gets disrupted.
VMNs.
Yeah.
Those are the first responders for bacteria.
Yep. Polymorphonuclear leukocytes. They're crucial for finding, eating, and killing bacteria. After a severe burn, their ability to do all that is impaired. That massively increases the risk of serious infection, sepsis, even death.
And there might be a genetic link, too.
Yeah, some emerging evidence suggests certain gene variations might make someone more prone to sepsis after a burn. And another growing problem is fungal infections, which can be really tough to treat.
And if an infection does take hold in the wound, how does that affect healing?
Well, tissue regeneration, the healing process, can't really get going properly until the infection is under control. So infection dramatically delays healing.
Makes sense.
And the longer a wound takes to heal, the higher the risk of bad scarring hypertrophic scars, those raised thick ones. The numbers are stark. Burns healing in under 10 days, only about a 4% risk.
Okay.
But if healing drags out past 21 days, that risk jumps way up, maybe to 40%. Really shows why preventing infection and speeding up healing is so critical.
Absolutely compelling reasons to look for therapies that can help with both. So let's get into the experimental data. What have animal studies shown about HBO2 for burns?
There's quite a bit of animal research, actually. Studies using rabbits, rats, mice, guinea pigs, they've pretty consistently shown significant reductions in edema, the swelling, burned tissues when the animals got HBO2.
Okay, reduced swelling. What else?
Several studies, especially in rabbits and rats, also reported faster healing times. Wounds closed up more quickly. And another common finding was lower infection rates in the burn wounds.
So less swelling, faster healing, fewer infections. Seems promising.
Yeah, it suggests HBO2 might be hitting multiple beneficial targets after a burn.
Were there any specific animal studies that were particularly influential or had really key findings?
Definitely. A really crucial one was by Gruber back in 1970. He found the tissue right under a third-degree burn was severely hypoxic, very low oxygen.
Hypoxic.
Right. And importantly, he showed that the only way to really raise those oxygen levels was by giving oxygen under pressure, which is, of course, what HBO2 does. That really set the stage.
Laid the groundwork.
Exactly. Then Ketchum, in '67, showed better healing and less infection in burned animals treated with HBO2. Later, his work showed dramatic improvements in the microvasculature, the tiny blood vessels, in burned rats getting HBO2.
So it wasn't just dumping more oxygen, it was actually improving blood flow too.
That's what it looked like. Hartwig in '74 confirmed a lot of this, saw less inflammation, and suggested HBO2 could be a good adjunct to early debridement, the surgical removal of dead tissue.
Okay.
Wells and Hilton did a really well-controlled study in dogs, found a 35% drop in fluid leakage into tissues with HBO2, and they showed it was the oxygen, not just the pressure.
That's an important distinction.
Very. They also saw less blood thickening and better cardiac output.
What about that systemic edema, the swelling everywhere? Did animal studies look at that?
Yes, Nylander's work showed HBO2 helped reduce that generalized edema in burned animals.
Okay. Kaiser's studies in rabbits were interesting. He found HBO2 actually made established third-degree burns shrink, while untreated ones grew. He also saw less swelling under the skin.
Wow, shrink. That's significant.
It is. Stewart and colleagues looked at deep, partial thickness burns in rats getting topical meds, the HBO2 group. Their skin structures were preserved, the burns didn't worsen to full thickness, and their ATP levels, cellular energy, stayed up.
While the untreated group's ATP dropped and burns deepened,
Exactly.
that ATP finding seems really key. Why is maintaining ATP so critical?
Well, it suggests HBO2 might be helping cells keep up the energy needed for vital functions, like the sodium pump. That pump helps cells maintain the right fluid balance.
Right.
When it fails after a burn, that's thought to be a big reason why endothelial cells lining blood vessels swell up, leading to massive fluid leak and edema.
Other researchers, like German Prey, also reported HBO2 reduced the overall extent of the burn injury. Miller and Korn saw faster skin regrowth, re-epithelialization in guinea pigs with HBO2. They linked it to preserved capillary integrity in the zone of stasis, which reduced wound drying.
So, lots of positive animal data. Any studies that didn't show a clear benefit or maybe were negative?
Yeah, there were a few. Perrins used a pig model, didn't find much difference in tissue destruction, but that study had limitations, short treatment time, didn't look closely at blood vessels, and pig skin is different from human skin.
Okay, context matters.
Definitely. Nicole's rat study didn't find HBO2 helped control bacterial counts. But interestingly, even with delayed treatment, they did see faster skin regrowth in partial thickness burns.
So maybe timing is really crucial for when you start HBO2.
Seems very likely, based on the literature. The chapter also draws parallels between burns and ischemia reperfusion injury.
Right, we touched on that. Blocked blood flow, then sudden return causes more damage.
Exactly. Similar things happen, ATP depletion, harmful oxygen species generated, and recent research shows HBO2 can be protective in ischemia reperfusion in organs like the heart.
How does it protect?
Things like boosting nitric oxide, reducing inflammation, promoting new blood vessel growth. These effects might help explain the benefits seen in burns, too.
That connection makes a lot of sense.
It does. Zamboni, for example, showed HBO2 stops white blood cells sticking to vessel walls in reperfusion injury, which helps keep blood flowing in those secondary damage zones. German Prey's data supports that.
Okay.
Although Shoshani's rat study, where all animals got standard silver sulfatazine cream, found no extra benefit from HBO2, contradicted some earlier work, maybe due to different methods.
Inconsistencies to explore.
But then Blezer and Beneschot, in a large rat study with big burns, reported HbO2 reduced burn shock and quadrupled survival rates.
Quadrupled survival, that's huge.
It is, and Tenenhaus found HbO2 reduced bacteria in the gut of burned mice. That's relevant because bacteria leaking from the gut is a major source of systemic infection after severe burns.
So HbO2 might help prevent those dangerous body-wide infections.
It's a definite possibility. Magnotti even proposed that multiple organ failure after burns might start with ischemia-reperfusion injury in the gut. If so, early HbO2 could help mitigate that.
Makes sense, given HbO2 helps ischemic tissues elsewhere.
Right, intestine, muscle, brain, heart. And a human study by Zhu on patients with large burns found HbO2 was linked to immune marker changes that resulted in less sepsis.
And the chapter mentioned early nutrition being vital too.
Yes, early enteral feeding nutrition via the gut is crucial for burn patients. Decreases complications, mortality, supports gut health. A stressed ischemic gut can actually fuel inflammation.
Okay.
And while oxygen is good for healing, low oxygen actually hurts the ability of those PMN immune cells to kill bacteria. But Mader showed HbO2 enhances PMN killing in oxygen-rich tissues. And Hussman found no evidence HbO2 suppressed the immune system in animals.
Feels like a lot of different pieces are fitting together here.
They are. Billick studied rats with deep second-degree burns getting silver sulfatazine. Found HbO2 gave additional benefits, reduced edema, boosted new blood vessel growth, increased regenerative hair follicles, and sped up skin regrowth time.
All positive signs.
And Turkislan showed HbO2 reduced the worsening of that critical zone of stasis in the first 24 hours and sped up overall healing, likely by helping new blood vessels form, supporting earlier work.
And then there's the really exciting stuff about stem cells.
Yes, that's a really promising area. HbO2 has been shown to mobilize stem and progenitor cells from the bone marrow in both humans and mice.
Mobilize them, like send them out.
Exactly. It seems to involve nitric oxide production in the bone marrow. These mobilized cells can then travel to wounds, including burns, and help build new blood vessels, vasculogenesis.
Wow.
Plus, HbO2 seems to directly stimulate stem cell growth and differentiation right at the wound site, possibly via an oxidative stress response that triggers healing signals.
And it helps recruit specific types of stem cells, too.
Yes, endothelial progenitor cells, the ones that line new blood vessels. HbO2 promotes their recruitment and differentiation through complex pathways involving proteins like thioredoxin-1 and HIF factors.
Okay, so summing up all this experimental data.
The overall picture from animal studies is pretty strong. HbO2 seems to consistently reduce dermal ischemia and edema, stop partial thickness burns getting worse, preserve microcirculation and cell energy, maybe boost bacterial killing, modulate ischemia reperfusion damage, and ultimately improve survival in animal burn models.
That's a very compelling body of preclinical evidence. Now let's shift to the clinic. Humans. Has this promise translated into real benefits for burn patients?
Well, there's a history of clinical observations going back decades suggesting potential benefits. Way back in 1965, WADA reported better burn healing in coal miners treated with HbO2 for CO poisoning.
Okay, an early observation.
Then later clinical series, Ikeda, WADA again, Lamy, Tabor, Grossman, they consistently reported things like improved healing, shorter hospital stays, lower mortality, reduced costs, better outcomes, even needing less IV fluids and fewer surgeries.
Consistent reports across different groups.
Yes. NEED did a large clinical outcome study, found a statistically significant drop in mortality, PG 0.028, in seriously burned patients treated with HbO2 compared to controls. Also saw fewer infections and noted it seemed to give surgeons more time to really assess the injury extent.
Sanchi's work gets mentioned a lot regarding potential cost savings, right?
Absolutely. He reported big drops in hospital stay for burns, up to 39% TBSA. And for larger burns, 40-80%, he saw less need for surgery like grafting.
Which means cost savings.
Significant cost savings per case, yes, based on his estimates. But it's important to say not every single clinical study has shown clear wins on every single outcome measured.
Okay, so were there studies with more mixed or less positive findings?
Yes. Weisbrunn did a retrospective study comparing HbO2 and non-HbO2 groups, reported more sepsis, worse kidney function, and lower white blood cell counts in the HbO2 group. Didn't find a clear effect on mortality.
That sounds negative.
It does, but interestingly, even that study found a huge 75% reduction in the need for skin grafting in the HbO2 patients. Statistically significant too, p 0.001.
So even a study with some negative findings showed a major surgical benefit.
Exactly. Other studies were more consistently positive. Merola's randomized controlled trial on partial thickness burns found HBO2 led to more healthy granulation tissue, faster healing, and less scarring.
Okay.
Cianci's earlier, smaller studies showed similar positive results in burns, around 28% TBSA. And his group also reported in those big 40–80% burns, HBO2 meant less IV fluid needed and less weight gain initially.
Less fluid requirement is a big deal in resuscitation.
It is. Maxwell's controlled pilot study reported less surgery, less resuscitative weight gain, fewer ICU days, shorter total hospitalization, less wound sepsis, and lower costs with HBO2.
And his larger study.
On those 40–80% TBSA burns, significant reductions in surgeries needed, length of stay, and total cost.
It really seems like reducing the need for surgery, especially grafting, is a recurring theme.
It definitely emerges strongly from the clinical experience. And even studies on induced wounds and healthy volunteers showed benefits. Hammerland found HBO2 reduced swelling and fluid leak from experimental blisters.
Okay.
And Niezgoda's double-blind, sham-controlled study using a human burn model carefully created small burns on volunteers found HBO2 reduced wound size, redness, and fluid leak compared to the sham treatment.
But not all trials were overwhelmingly positive across the board. You mentioned Brannon.
Right. Brannon's 1997 randomized trial didn't find significant differences in mortality, operations, or length of stay, but it had limitations. Many patients started HBO2 late, and both groups got very aggressive early surgery.
Confounding factors.
Possibly. And interestingly, a later look at that study's data did find the HBO2 group had less fluid loss, drier wounds, earlier healing, and significantly lower hospital costs. So sometimes the benefits aren't obvious in the main headline results.
So a complex clinical picture. Some clear benefits, some nuances. Now let's look at more recent perspectives. How might HBO2 impact specific things like, say, pain management?
Sutherland reviewed the literature, concluded HBO2 seems to have a significant pain-relieving effect, but stressed we need more good studies on safety and efficacy specifically for burn pain.
And that's important because opioids have downsides.
Exactly. Heavy opioid use can suppress the immune system, potentially leading to worse outcomes. Plus, nerve pain is common and really hard to treat after severe burns.
Okay.
Rasmussen's study on volunteers with first-degree burns found HBO2 had a potent pain-blocking effect, suggesting it might work centrally, desensitizing the nervous system.
Interesting mechanism.
Chone's pilot study in burn patients didn't find big differences in inflammation markers or burn depth, but saw fewer positive bacterial biopsies in the HBO2 group, though it was a small study.
Underpowered, maybe.
Possibly. And Jones's work on diabetic foot burns, similar issues with blood flow, showed HBO2 plus standard care led to better healing, fewer amputations than standard care alone. Some patients scheduled for grafts even healed just with HBO2.
Wow. Avoiding amputation is huge. What about recent findings on immunity and infection with HBO2 and burns?
Zhang showed in a model that HBO2 can reduce cell death and inflammation in ischemic wounds. Tom found HBO2 can inhibit beta-2 integrins sticking to blood vessel linings. These molecules help recruit immune cells.
So inhibiting them could be good early on, reduce excessive inflammation.
Potentially, yes. At the higher pressures used in HBO2, might prevent some early damage.
And the stem cell research continues to look promising.
Absolutely. Tom's work keeps showing HBO2 boosts stem cell populations in the marrow and helps them migrate to wounds. And Stewart's earlier finding about preserved hair follicles with HBO2, that might also reflect stem cell activity in the skin. It suggests HBO2 might be tapping into the body's own repair crews.
That's a great way to put it. What about the old concern about oxygen toxicity? Any new perspectives there?
Sharetta's study on chronic wounds found HBO2 actually enhanced the body's natural antioxidant defenses. It also seemed to activate inflammation resolution, new blood vessel formation, and blood vessel tone regulation.
So potentially protective rather than toxic in that context.
In that context, yes. Acute oxygen toxicity is considered pretty rare with standard clinical protocols for burns. It's more a concern with the much longer frequent treatments for things like decompression sickness.
Okay. Now, inhalation injury, we know it makes burns much worse. Any recent insights on using HBO2 in those really complex cases?
Right. Combining a big burn with inhalation injury ramps up mortality, instability, edema, fluid needs, lung problems.
Yeah.
That's bad news. But Grimm found no signs of increased oxidative stress in exhaled gases from HBO2-treated burn patients, even with inhalation injury.
That's reassuring.
And Ray studied severe burn patients with inhalation injury and ARDS, that serious lung condition, found no harmful effects from HBO2, even with high oxygen levels on the ventilator.
No harm. Any benefit?
Yes. Patients in the HBO2 group got off the ventilator much faster, like 5 days versus 26 days, statistically significant, and huge cost savings.
Wow, 5 versus 26 days is massive.
It is. And importantly, there's no current evidence contradicting these findings. Suggests HBO2 might be safe and potentially helpful even in these toughest cases.
The chapter mentions that big 2009 Cochrane review on HBO2 for burns. What did it conclude? And have things changed much since then?
Right. The Cochrane Review is a big deal in evidence-based medicine. They looked at 4 randomized controlled trials, RCTs, but only 2 met their strict criteria, Hart and Brannon, the ones we discussed. They felt the studies were too different to combine the data. Hart showed faster healing, but they thought the study might be too small. Brannon showed no difference in main outcomes, but had limitations.
So the conclusion was?
Insufficient high-quality evidence at that time to strongly recommend for or against routine HBO2 use for burns. They called for large, multi-center RCTs.
The gold standard.
Exactly. Now, the review didn't include several matched control studies that showed benefits, and this chapter argues that experienced clinicians' observations also have value. The need for a big RCT is still there, but they're hard to do because single centers don't see that many huge burns.
So highest level evidence still pending, but lots of promising data and experience. Which brings us to the practical side. How is HBO2 actually used in managing burn patients? What's the surgical perspective?
Well, burn care has shifted towards aggressive early surgery, excision, and grafting. In that world, HBO2 is seen as a valuable adjunct, especially for deep second-degree burns.
Adjunct means in addition to,
Yeah.
right? Not instead of surgery.
Correct. Especially helpful in tricky areas like hands, face, ears, where precise surgery is tough and grafting complex. Using HBO2 with topicals, debridement, dressings can buy healing time, let the injury declare itself more clearly before definitive surgery.
And sometimes avoid grafting altogether in deep partials.
Yes, it's been observed to significantly cut healing time there, potentially avoiding grafts. Theoretical benefit, too, for less defined third-degree burns, maybe saving borderline tissue, and it helps in fourth-degree electrical burns by reducing compartment pressures in muscles.
Okay.
It also helps with reconstructions using flaps and grafts. Surgeons might even call for it during surgery if a flap looks like it's struggling for blood supply.
So it requires close teamwork.
Absolutely. Burn units using HBO2 need staff trained in both hyperbaric critical care and burn specifics. The hyperbaric unit should really be an extension of the burn unit, part of the team.
And how is the therapy itself given? The protocol?
Ideally, you start ASAP, often during resuscitation. Typical session is 90 minutes breathing 100% oxygen at 2.0 to 2.4 atmospheres pressure.
In the chamber?
Right. Maybe 3 treatments in the first 24 hours, then twice daily. Adult protocols are now generally considered safe for kids, too.
Constant monitoring.
Continuous monitoring during and after. Ventilator support is possible in compatible chambers. Fluid management is critical. You need special pumps for high rates under pressure.
And watch for blood pressure drops after.
Yes. Careful volume assessment needed. Keep the chamber temperature comfortable. Febrile patients need extra close watching due to a slightly higher theoretical risk of oxygen toxicity.
How long does treatment usually last?
For big burns, over 40% TBSA, maybe 10-14 days, working closely with the surgeon. Many partial thickness burns might heal without surgery during that time.
Longer treatments.
Beyond 20-30 sessions is usually for optimizing grafts. Rarely go past 40-50 sessions total. Utilization review is recommended around 30 sessions.
Any specific drug interactions or issues?
The main one mentioned is mafenide acetate cream, sulfamylon. Potential for CO2 buildup under it, so usually removed before HBO2. Silver sulfadiazine is more common now. And watch for ear barotrauma and head neck burns might need an ENT consult.
Multiplace or monoplace chambers?
Either works. But transporting critical burn patients long distances for HBO2 isn't ideal. The chamber should really be in the same facility as the burn center.
You mentioned utilization review around 30 sessions.
Yes, that's the recommendation. Just to formally check if continued treatment is still needed and appropriate. Ensure efficient use of the therapy.
Okay, let's loop back to cost. Burn care is crazy expensive. Does HBO2 add a lot, or can it save money overall?
Well, there's obviously a cost to providing HBO2, but the chapter emphasizes that numerous studies suggest it can actually lead to overall cost savings.
Oh.
Mainly by reducing healing time, shortening hospital stays, and decreasing the need for surgeries, especially those expensive grafting operations.
Got it.
The chapter points to 6 studies that specifically looked at costs. They estimated average savings with HbO2 ranging from about $76,000 up to $120,000 per patient.
So an upfront cost, but potentially big savings down the line.
That's the argument, yes. A compelling factor to consider.
So pulling this all together, what's the big picture takeaway from this deep dive into HbO2 for burns based on this chapter?
Well, despite huge advances, mortality for the biggest burns hasn't budged much since the 80s. Early surgery helped smaller burns, but not the massive ones as much.
The floor of survival idea.
Exactly. Some experts think we've hit a plateau with current standard care for the most severe cases. This chapter argues that breaking through likely needs new adjunctive therapies, like HbO2.
And the evidence for HbO2.
We've seen decades of animal and human studies showing benefits, reversing stasis, reducing ischemia, stopping burns deepening, moderating inflammation, lessening fluid leak, preserving skin structures, reducing grafting needs, shortening stays, lowering costs.
A lot of potential benefits.
Yes. The burn community knows we need to do better on pain, healing speed, scarring. Progress there has been limited, as experts like Wolf have noted. So this chapter really pushes for the burn community to seriously consider HbO2's role.
And Dr. Boykin's quote.
Right, that HbO2 offers a unique environment for recovery that other therapies don't match. Most clinical observations suggest less morbidity, shorter stays. There's a strong scientific basis. And our understanding of how it works, stem cell signaling, is growing fast.
So potential to raise that floor of survival.
Potential to raise the floor, enhance healing, improve quality of life. Yes. Obviously, definitive proof waits on those big RCTs. But while we wait, the experienced clinicians' observations are still valuable.
And the current bottom line.
Current data suggests HbO2 as an adjunct in comprehensive care can significantly improve outcomes, reduce surgeries, shorten stays, and be cost-effective. It's safe when done right. Given its unique effects on healing mechanisms, formally investigating its integration into early burn care via well-designed multi-center studies seems really warranted.
So to really boil down our deep dive today, this chapter strongly suggests HbO2 offers support for burn recovery on multiple fronts: cellular, physiological, clinical, backed by a pretty wide range of evidence.
That sums it up well. And yes, while we wait for more research, especially those big RCTs, to fine-tune things, the existing evidence and clinical experience paint a really compelling picture of HbO2's potential as a valuable extra tool in the tough fight against burn injuries.
Right. So here's a final thought for you, our listener. Considering just how complex severe burns are and the challenges that remain in treating them, how might embracing therapies like hyperbaric oxygen therapies that seem to tackle multiple parts of the healing problem, how might that reshape the future of burn care? Could it lead to real improvements in outcomes and quality of life for patients? We definitely encourage you to look more into the research we've discussed and the broader field of hyperbaric medicine. It's a truly fascinating area.